Yes, we
Hello,
love AI.
hello everyone, and happy holidays from WEDI. I'm Michael McNutt, VP of Education and Marketing, and welcome to a WEDI Privacy and Security Workgroup event, Protecting Privacy and Reproductive Healthcare, Navigating Recent Regulatory Changes. It's my pleasure to introduce Leslie Berkeheiser and Tantian Nguyen, the co-chairs of WEDI's Privacy and Security Workgroup.
Good afternoon, everyone. Good morning if you're on the West Coast. I'm Leslie. My co-chair Tantian and I are so pleased today to have you being able to attend this all members meeting with us. This is in place of our normal monthly privacy security work group meeting, and we always have plenty of topics across cybersecurity, privacy, and security. So we are always recruiting and very happy to expand this meeting where our Deputy Director for Health Information Privacy, Data, and Cybersecurity from OCR, Timothy Noonan, is joining us today. Just a couple of quick housekeeping items for all of you, and then we're going to jump right into the presentation, and I'll do a quick announcement for Tim. Bottom line is we are so honored today to have this call. If you had the opportunity and the pleasure to listen to Tim Noonan at our October DC conference, he's going to be building on a number of the statements and information released during that time frame. And obviously, there have been things that have happened since then, believe it or not. Things are happening on a daily basis. We will be taking your questions today during the presentation. As Tim transitions from one topic to another, he's going to pause and we'll be monitoring the chat. So questions will be asked through the chat. Please go ahead and familiarize yourself with that if you're not ready for that now. And do please look for implementation types of items. I remember listening to Tim in DC, and I walked away with about 6 different things that I thought, oh, these are things that our work group could really take as actionable items, way to assist our industry, which is, of course, our goal and mission on implementing all of these rules and proposed rules and just the responses from breaches and cybersecurity, but ways that we can help in education awareness and also in practical tips and documents and things like that. We'd like to be mindful as well. Some of these topics that Tim's going to cover may be subject to litigation or, as he mentioned yesterday to me, he doesn't have a crystal ball about 2025 and how things may change with our new administration. So if you could keep all those things in mind, with that, it's my pleasure to introduce Tim Noonan as Deputy Director for OCR for Information Privacy, Data, and Cybersecurity. And in this role, he leads OCR's administration and enforcement for all of HIPAA, as well as breach notification rules, Patient Safety, and Quality Improvement Act. This includes investigations, rulemaking, guidance, and outreach. Tim, with that, we are so excited to have you today. I'm going to go off camera and we'll be supporting you from behind the scenes.
Great. Thank you, Leslie. Thank you, everyone. Appreciate the invitation. I had the pleasure of speaking at WEDI in October and thought it was a one-night performance only, but been brought back for an encore performance, if you will. So we'll explore and discuss some of the things that I spoke of in October. There's some updates that I can provide some information on. I understand the nature of today's meeting, and the interest is on OCR's recent final rule regarding reproductive healthcare privacy. So we'll spend the bulk of our time discussing that, but also try to hit on some other topics that I think you'll all be interested in, give you some information on the final rules we've done this year with Part 2, the upcoming proposed modifications to the HIPAA security rule. We can go ahead and next slide. We'll discuss some of the trends that we see in large breach reports, such as the number of large breaches reported and the number of individuals affected, and types and location. Discuss some recent enforcement activity. We've been releasing quite a few press releases already in the month of December on completed enforcement actions. Talk about some enforcement initiatives that we've implemented and continue to be in place. And then, as always, I think just trying to identify resources that I think will be helpful. We released some new resources in October, including a new video on ransomware, which try to be topical to what's happening in the real world. And we'll, as Leslie said, we'll stop at the end of each section take questions, and really, maybe offer some thoughts as to things that WEDI can assist OCR with in terms of messaging the different activities that we're engaged in, as well as needs. What does the industry need? What are ways that OCR can be more helpful or more responsive to the issues and the challenges that you all have in implementing the rules or dealing with cybersecurity and privacy issues. So with that, next slide, please. So first, thought it might be useful just to identify some of the key dates associated with the HIPAA privacy rule to support reproductive health care privacy. So this was first published in the Federal Register, April 26, 2024. All federal rulemaking will be published in the Federal Register. That's the federal government's newspaper, if you will, that gives you official notification. Its effective date was June 25th, 2024. So over the summer, the modifications implemented in the final rule became effective, which means regulated entities, covered entities, and business associates should implement these changes on June 25th, going forward. We often get asked, effective date, compliance date, what is the difference? So the effective date is when the rule becomes effective, and then the compliance date is the date that OCR can take enforcement action. We can investigate, and if we found a violation with the new rules, beginning on December 23rd, we're able to enforce those rules. For this particular rule, that's true. So December 23rd, 2024 is the compliance date. However, there is an exception for the Notice of Privacy Practices provisions that has a separate and different compliance date. That's February 16th, 2026. And so why the different date? Earlier in the year, we did the Part 2 final rule on the confidentiality of substance use disorder patient records. And so those changes go into effect on February 16th, 2026. They will require regulated entities to change their notice of privacy practices. And so what we thought to do is make it a little less burdensome for regulated entities and having to change your privacy practices twice in a couple of years. You can do it all at once, and you've got a little time to do that. So we had those dates for both privacy practices be the same. Next slide, please. So the final rule strengthens privacy protections by prohibiting the use or disclosure of protected health information by a covered entity or their business associate for either of the following activities. And so it's prohibited for conducting a criminal, civil, or administrative investigation into or impose criminal, civil, or administrative liability on any person for the mere act of seeking, obtaining, providing, or facilitating lawful reproductive health care. It also prohibits the identification of any person for the purpose of conducting such an investigation or imposing such liability. There's a rule of applicability, and what that does is it limits the prohibition. The prohibition applies where a regulated entity has reasonably determined that one or more of the following conditions exists. So the first one, the reproductive health care is lawful under the law of the state in which such health care is provided. So, for example, if a resident of one state traveled to another state to receive reproductive health care that is lawful in the state where such health care was provided, then the rule would apply. Second instance is where the reproductive health care is protected, required, or authorized by federal law, including the U.S. Constitution, regardless of the state in which such health care is provided. For example, if the reproductive health care, such as contraception, that's protected by the U.S. Constitution, and in that case, then the prohibition would apply. It's lawful health care. The third instance is where the reproductive health care was provided by a person other than the regulated entity that's receiving the request for protected health information. And the presumption, which I'm about to describe, applies. Next slide, please. Back when we did the notice of proposed rulemaking, there was a 60-day public comment period, and we received a lot of comments discussing that regulated entities are often not in possession of information about the circumstances surrounding the provision of healthcare if they're not the ones that provided such care. And so they expressed, the challenges of determining the lawfulness of healthcare when it's provided by an outside entity. And so in response, we added a presumption that we believe reduces the burden of the new prohibition on regulated entities while still maintaining the same levels of protection. And so the way it works is where a request for protected health information is made of a person that did not provide the reproductive health care at issue. Such reproductive health care is presumed to be lawful under the circumstances in which it is provided, unless one of the following circumstances exists. So the presumption is it was lawful unless, what I'm about to say, one of these exceptions applies. First exception, the regulated entity has actual knowledge that the reproductive healthcare was not lawful. So, for example, if an individual disclosed to their doctor that they obtained reproductive healthcare from an unlicensed person, and the doctor knows that the specific reproductive healthcare must be provided by a licensed healthcare provider, that could be an instance where the regulated entity has actual knowledge that the healthcare provided was not lawful. And if the healthcare provided was not lawful, then the prohibition does not apply. Second instance, the regulated entity is in possession of factual information supplied by the person making the request for protected health information that demonstrates a substantial factual basis that the reproductive health care was not lawful. So an example here would be a law enforcement official provides a health plan with evidence that the information being requested is reproductive health care that was provided by, again, an unlicensed person, where the law requires that such healthcare be provided by a licensed healthcare provider. In that instance, the regulated entity receiving that information from the requester could have a substantial factual basis to demonstrate that the healthcare provided was not lawful. And again, the prohibition only applies, as we talked with the rule of applicability, to lawful healthcare. Unlawful healthcare is not protected by this rule. To implement the prohibition, the regulated entity must obtain a signed attestation when it receives a request for protected health information, potentially related to reproductive health care, that the use or disclosure is not for a purpose prohibited under this final rule when the request is for any of the following purposes. And so the rule only applies to requests for protected health information in 4 instances. The first is health oversight activities, judicial and administrative proceedings, law enforcement purposes, and disclosures about decedents to coroners or medical examiners. And so what the attestation does, it provides regulated entities with a way to obtain a written representation from a person requesting protected health information that their request is not for a purpose prohibited by this final rule. In order to assist regulated entities, we published a model attestation that's available on our website. And so there's no requirement that the model attestation be used, but it is something that if regulated entities want that to be the form that they receive, they can use that as they see fit. Next slide, please. And I should, before discussing resources, I should talk a little on notice of privacy practices. So the 2024 HIPAA privacy rule addresses proposals related to the notice of privacy practice provisions made in both the 2022 Part 2 notice of proposed rulemaking, that's the one that we did with SAMHSA, as well as the 2023 HIPAA privacy rule notice of proposed rule modifications. As I said earlier, the compliance date for the changes made for notice of privacy practices aligns with the compliance date for the 2024 Part 2 rule, February 16th. 2026. And the notice of privacy practice provisions have been revised to require a covered entity to, among other things, provide the following information in a notice of privacy practice. And so what's new would be including descriptions and examples of the types of uses and disclosures that the new 2024 HIPAA privacy rule prohibits, and those for which an attestation is required. A statement putting the individual on notice of the potential for information disclosed pursuant to the privacy rule to be subjected to redisclosure by the recipient of protected health information and no longer protected by the privacy rule. So what are we saying there? There are instances where protected health information is permissible to be disclosed to an entity that is not regulated by HIPAA. And as I think everyone knows, HIPAA doesn't follow health information everywhere. It only protects health information when it's in the possession of regulated entities, covered entities and business associates. So for instance, health information that goes to law enforcement is not covered by HIPAA. And so law enforcement can make redisclosures and it wouldn't violate HIPAA because HIPAA doesn't apply to them. It's not to say there couldn't be other laws that could affect what an entity not regulated by HIPAA can and cannot do. I'm only speaking to what HIPAA can do. HIPAA has limited jurisdiction, and so when information flows to an entity that's not subject to that jurisdiction, HIPAA doesn't apply, but there could be state or other federal laws that have different requirements. Okay, here, this is a good slide to spend a couple minutes on, or to take a screenshot if it's helpful. It's just a listing of some of the different resources that are currently available to assist regulated entities with this rulemaking. So start with the first one. As I said, the Federal Register is more or less the federal government's newspaper. So we do have the final rule published on the Federal Register's website. It can be viewed or downloaded by going to that link. When we announced the final rule, we also put up a fact sheet on our website that goes through the major provisions of the new rule. As you heard me mention, we published a model attestation that entities can use to comply with this rule. It's available at the link there. We just a couple weeks ago did a short video on our YouTube channel about the attestation requirement, the model attestation, and this is done by OCR's director. So please check out our YouTube channel. We also did a webinar, I did, on our YouTube channel, where I discussed the final rule in much greater detail. I think it's a little over an hour. It's got, I think last time I checked, over 2,500 views. So I spend quite a bit of time going through preamble, all of the specific provisions in the new final rule. So that can be a great place to start if you're wishing I had said more about something, or you want further clarification or more information. Webinar can be great, or if just downloading the final rule itself or fact sheet can often help identify things. We also published a social media toolkit to educate, inform, and ensure access to high quality information about this rule and key messages that regulated entities can use when communicating about this new rule with patients and beneficiaries and others. And then we also have 2 videos in English and Spanish featuring our director with a message about the new rulemaking. So one thing I want to touch on before leaving reproductive healthcare privacy is just to make folks aware. So this final rule is subject to litigation. And so in one lawsuit, state of Texas versus HHS, back on September 4th, 2024, Texas filed a lawsuit seeking injunctive relief against the 2024 HIPAA privacy rule and the 2000 HIPAA privacy rule. The complaint asserts that HHS violated the Administrative Procedures Act. There's also a second lawsuit that was filed by a doctor in Texas on October 21st, 2024, also seeking injunctive relief against the 2024 HIPAA privacy rule. Complaint also asserts that HHS violated the Administrative Procedures Act. So both of those complaints are seeking injunctive relief. And as you heard Leslie say, so I won't offer comments on litigation. We generally don't do anything like that. But I will just say if there's any changes, if there's any ruling by a court that affects anything with respect to this rulemaking, we will put out that information. Later in the slideshow, we'll have a page that talks about our listserv. But if you're not currently a member of our listserv, just remember this when I bring it up again. You should consider joining our listserv. So we do put out listserv announcements with great frequency, often highlighting recent completed enforcement actions, new rulemakings, guidance videos. We recently held a conference, a cybersecurity conference in October that was put out there. So anything in litigation that affects this final rule, we'd be put out a listserv announcement. There'll be information on our web pages, et cetera. So do stay tuned as that's as a still subject to the court, and we're waiting to hear what next steps may occur from that litigation. Next slide, please. I'd also like to highlight briefly the other final rule that we published earlier this year that also impacts HIPAA and regulated entities. This is the confidentiality of substance use disorder patient records, Part 2, otherwise known. And so back in February, OCR and SAMHSA published this final rule. This was required by the CARES Act. That was a law that Congress had passed, where they wanted there to be a modification of the Part 2 rules to implement requirements to better harmonize the Part 2 confidentiality requirements with certain permissions and requirements of the HIPAA rules in the HITECH Act. And I think what it is it was congressional recognition that the healthcare sector has a lot of regulations, a lot of rules applying to it, and at least in the privacy space, there might be an opportunity to bring greater alignment and make it a little easier, hopefully, for regulated entities to comply with the different requirements while easing some of the burden. And so, as you've heard me mention before, the compliance date for these rules is February 16th, 2026. Just a couple of highlights that I think are useful for the audience to understand and to think about things that OCR can do or WEDI can assist with to help with this rulemaking as well as anything else that we're doing. The final rule creates a new option for patients to provide a single consent for all future uses and disclosures of Part 2 records for treatment, payment, and healthcare operations without the Part 2 program having to get the consent from the patient for each future use or disclosure. So an example, upon receipt of such a consent, a Part 2 program could use the patient's Part 2 records for healthcare operations, such as reviewing the competence or qualifications of a healthcare professional, evaluating practitioner and provider performance, or conducting training programs, without having to seek the patient's consent for each use and disclosure. And this would continue unless or until the patient revokes the consent. Another change is for redisclosures. This now permits the redisclosure of Part 2 records in accordance with the privacy rule by recipients that are HIPAA covered entities, including those that are Part 2 programs. So there's certain Part 2 programs that may be covered by HIPAA or may not be. So for Part 2 programs that are a HIPAA covered entity, just like any other HIPAA covered entity now, as well as business associates, they can redisclose to the limits of the privacy rule. So not a change for Part 2 programs that are covered entities. They probably already familiar with that, but for the Part 2 programs that otherwise haven't had this, there's a slightly different change. A Part 2 program that is not a HIPAA covered entity, they would be permitted to redisclose the records according to the scope of the patient's consent. So Part 2 programs that are HIPAA covered entities, they can redisclose per the HIPAA privacy rule. Part 2 programs that are not HIPAA covered entities, they're limited to redisclosure in accordance with the patient's consent. Final rule adds a couple of patient rights that I'll touch on briefly, as these are HIPAA rights. So I think everyone's probably familiar with these. So for Part 2, new patient rights added were for an accounting of disclosures of Part 2 records and a right to request restrictions on disclosures of Part 2 records. And these function just like their HIPAA counterparts. With respect to accounting disclosures, patients now would have a right for an accounting disclosure of Part 2 records made with patient consent, and to disclosures for treatment, payment, and healthcare operations made through an electronic health record for a period of up to 3 years. So a patient will be able to request an accounting disclosure of their Part 2 records to learn if there's been any disclosures in the past 3 years to other treating physicians, for example. The final rule also implements two rights with respect to restrictions on disclosures of Part 2 records. One is, again, just like HIPAA, there's a right for patients to request, and the key word there, keywords, is request. A right for patients to request restrictions on disclosures of their Part 2 records, otherwise permitted for treatment, payment, and healthcare operation purposes. And so here, a patient could request restrictions. Patient in treatment for substance abuse may ask if their substance use disorder counselor not to disclose information about a history of childhood trauma when referring the patient for drug testing. And the substance use disorder counselor, they're not required to agree with the request on the restriction, but if the counselor does agree, then they are required to withhold that information. And that's exactly the way it works with HIPAA. The second one is a patient right to obtain. So the key word there is to obtain, which differentiates from the previous one. It was to request. So a patient has a right to obtain restrictions on disclosures to health plans for services paid in full by the patient. For example, a patient that's a member of their spouse's health plan and is receiving treatment in a Part 2 program, they can request and obtain restrictions on disclosures to their health plan of records about their substance use disorder treatment appointments when they've paid for the appointments in full out of their own pocket. In that instance, the Part 2 program would not be permitted to disclose the Part 2 records about those appointments to the patient's health plan. Next is really one of the most significant changes, and one I would asterisks, underline, emphasize. It creates civil enforcement for violations of the confidentiality provisions of the Part 2 regulations for the first time in Part 2's history. Previously, the enforcement of the confidentiality provisions was limited to criminal sanctions. Now, in addition to potential criminal penalties, Part 2 program could be subjected to a civil money penalty for violating the Part 2 confidentiality requirements. Patients now have a right to file complaints of violations of the Part 2 confidentiality provisions with the Secretary of HHS, in addition to a right to file directly with a Part 2 program. And HHS now has civil enforcement authority to investigate complaints and initiate compliance reviews of Part 2 programs concerning the confidentiality violations and imposing civil money penalties. And again, this, just like HIPAA, the same idea in the future, a portal will be developed for receipt of complaints, and investigations will be initiated, and it'll likely be very, very similar to the program that HHS has been doing for years with respect to HIPAA investigations. There's also now a requirement for Part 2 programs to report breaches to the HHS Secretary in the same manner as the HIPAA breach notification rule. And so this is modeled very much after the HIPAA breach notification rule of 60 days, requirements, large breaches, all that sort of stuff. So, and again, a similar portal will be set up for the reporting of breaches for Part 2 records. We do have some resources available to assist with this new rule. As you see, the Federal Register website, final rule may be viewed or downloaded there. We published a fact sheet to assist in understanding this new rule. And then we also did a webinar I did on the new rule, again, about an hour. It's available on our YouTube channel. It's got about 3,400 views, so it's attracted some attention. And it's the same thing, really walk through in detail the changes for each section, examples from preamble, reg text, really just trying to explain it in greater detail, and hopefully, maybe something that if you, folks are looking to train staff, is something that they could use. Can't guarantee people won't fall asleep during it, but if you press play and let folks review that could also be part of workforce training to make sure staff are familiar with the new changes. Next slide, please.
Tim, just a quick interjection here. Is there a point that you might want to stop and ask for any questions in the chat?
Yeah, I got one more. I was just going to talk about the security rule briefly, and then I thought we would and talk about any rulemaking questions.
Thank you.
Sure. Last, I just want to highlight for everybody, we are intending to propose modifications to the HIPAA security rule. It's been a little while. It was security rule was first published in 2003. It establishes the national standards to protect electronic protected health information created, received, maintained, or transmitted by covered entities and their business associate. It sets forward the administrative, physical, and technical safeguards that are required. Although it's more than 20 years old, we believe the concepts employed in the current security rule remain very, very relevant today as when first promulgated. Again, the idea that you need a risk analysis or regular system activity review or access controls are still very much needed and part of effective cybersecurity. However, OCR has a long history of administering and enforcing the security rule, and so we believe we can make modifications that will improve cybersecurity, strengthen the requirements, and address issues that have come up in complying with the security rule as well as our investigations. Since the publication of the original security rule, there's just been an evolution in the technical capabilities of electronic record systems and the costs of security measures. Think back to encryption. Encryption's now fairly ubiquitous, but certainly less so back in 2000. So we added it. Just a quick plug here. We added it to something's called the Unified Agenda. And so it was first added to the fall 2023 HHS Unified Agenda. It's in the spring 2024 HHS Unified Agenda, and the fall 2024 Unified Agenda is about to come out later this month. And so the Unified Agenda, for folks that are not familiar, you see the web link at the bottom of the page for reginfo.gov. That's a great place to go where you can see all of the anticipated federal rulemaking, not just OCR, not just HHS, but all federal agencies. It's called the Unified Agenda of Regulatory and Deregulatory Actions. And so that's something you can take a look. You'll see within HHS, you'll see rulemakings. They're listed for CMS, ONC, OCR, FDA, and then outside of HHS, the Department of Ed or any other federal agency. And so that's a great way to be able to anticipate rulemakings. There are no guarantees, but we projected we would be publishing security rule in December of 2024. That's currently our plan. And if you go to that link, you can see what other rulemakings that you might be interested in. And it's a great way of planning, particularly if you want to do respond by providing comments on rulemaking, which is, again, very, very helpful for federal agencies that are engaged in rulemaking and getting vigorous, robust comments from the regulated community, industry, people with interests, stakeholders in this area is just super helpful for us. And I will tell you, for OCR, I imagine it's true for all federal agencies, but we do read every single comment. All the comments are gathered. They're organized by topic category. We go through every single comment. And so your thoughts and opinions count. They matter. And, really encourage when we publish the security rule for folks to provide feedback. Okay, so as promised, I think we'll take a slight pause here and see if there's any questions that have come up that I can try to be helpful on.
We actually do have a few questions, Tim, but the first one, if I may take it, it's a sort of an administrative questions. Everyone might be concerned about whether the recording of this session and the slides would be distributed afterward, and I'm assuming it would be yes, but I would ask Michael and Ariana if you could please sort of put in the chat about the recording and the slides, making it available to our attendees here. Now, the first question related to the topic under discussion here, Tim, is number one, the fact that the HTI-2, which we had talked about at the beginning of the session here, was released, was dropped today, and it will be published in the Federal Register of December 16. There's a question whether that might impact any of the privacy rules under discussion here. Although sort of a quick read through that means we see that information blocking exception was removed. And in fact, most everything's removed except for the TEFCA requirement.
Sure. I appreciate the question. I generally don't comment on other federal agencies' rulemakings, particularly if I haven't read it from cover to cover. So I think the idea behind information blocking, there is some nexus overlap between reproductive healthcare privacy and potentialities for information blocking. And so I would defer to ONC, but our rule making stands alone. So you want to follow HIPAA, to the extent that there's another rule making that could have some applicability. You'll certainly want to consult with that, but in all of our communications with ONC, they've been very supportive, and they've tried to make changes to their information blocking regime so that you're not put in a position where you're conflicting with either HIPAA or information blocking. And my understanding is the most recent changes facilitate that as well.
Great. The next question relates to the 42 CFR Part 2 that we discussed a few slides ago.
Okay.
Our Janice has a comment that the patient has to agree that the consent covers redisclosures, right? Before that could be made, could be disclosed to the requester.
Right.
It's not automatic.
The patient's in control of their consent, and so it's whatever they consent to.
Okay.
Mm-hmm.
And then the next question is relating to the HIPAA security rule here that we are expecting to be published soon within the month. What is the possibility that this rule might be frozen or pulled back, given that we have a new administration coming in?
Yeah, I don't speculate on what may or may not happen. So you take a step back, I suppose. So I've been through multiple administrative changes. I've been in federal government, I think, for nearly 20 years. So this is not the first time I've experienced something like this. What will happen next will be dependent upon what permanent new political leadership is brought on board, and we don't know until those folks arrive. We sit down and talk with them, and then every administration has its own set of priorities, and so we're at that strange period of time, if you will, where we're finishing up the priorities of the current administration, and then we'll have a new administration, and those things will be things that will be discussed. So I can tell you from past experiences, any rulemakings that get caught in between administrations, so something that's been published by the outgoing administration, that's always at the top of the list in terms of items to discuss, and so that'll be the subject of future discussions. But I wouldn't speculate as to how those discussions will go or what decisions will be made, because that's all coming in the near future.
Right. You're right. This is not the first time, and it's not the last time either. But for me personally, I mean, there's been so much work going into here, and security is a national, healthcare security is a national security factor. So I actually don't expect any impediment to this, but don't quote me on that. I don't gamble. So we have a next question from Rob Tennant here, that in many of the recent enforcement actions announced by OCR, OCR had identified that the lack of an appropriate risk analysis conducted by the covered entity is part of, the finding and the civil monetary fines. Can you discuss in general whether this was sort of a lack of a risk assessment being conducted at all, or is that the quality of the assessment was just not up to snuff?
Sure. So it's a very good question. I often describe it if you think of HIPAA security rule violations as a word cloud. Undoubtedly, the biggest word in the word cloud would be risk analysis. It's a stumbling block for many regulated entities. The deficiencies we see in risk analyses is they're not accurate and thorough. And so some examples, what does that mean? So it can mean in some instances, no risk analysis was attempted whatsoever. More frequently, it's smaller entities that aren't as sophisticated as they need to be with respect to the HIPAA security rule requirements. That's typically where we'll see instances where they've just never tried to do a risk analysis. For more sophisticated entities, what we see more often is there's efforts made, but the efforts made are not sufficient. So what do I mean by that? Many times what we're given is a gap analysis instead of a risk analysis. And so we have a cybersecurity newsletter. We'll point you to some resources later on our program today, but we did a cybersecurity newsletter previously a couple of years ago on the difference between a gap analysis and a risk analysis. A gap analysis is basically assessing your compliance with the HIPAA security rule requirements. So you might flag, we're not conducting regular system activity review. It's not anywhere, it's a necessary item. A gap analysis can be extremely helpful. So I don't want to disparage or discourage the use of gap analyses to improve cybersecurity, but it is not a risk analysis. A risk analysis is an assessment of the potential threats and vulnerabilities to electronic protected health information, all places that it may be stored, maintained, held, transmitted, etc. So you're flagging compliance deficiencies with respect to compliance with the HIPAA security rule, good, helpful, necessary, but not sufficient, because you're not accounting for the potential threats and threats and to protected health information. And that's really the purpose of the risk analysis. If you just identify what standards you haven't fully implemented, that's not accounting for instance, do you have mobile devices hooked up to your system? Are you accounting for the protections on those mobile devices? Yeah, we've had cases in the past, mobile devices weren't encrypted. And so when you lost a mobile device, that was something that was perhaps more frequent in years past. It created problems because there could be health information stored on the mobile device that now somebody has access to, or there's a means to access your electronic health record system through the mobile device, and so they have access to your system. And if it wasn't encrypted, then you've got real problems. So most frequently with, say, larger entities, more sophisticated entities, what we see is the risk analysis just is not sufficient. It doesn't account for all the physical locations. So maybe an entity has more than one physical location. It's got 15 clinics spread out over 2 states, and the risk analysis only accounts for 5 of them. So that means you haven't accounted for the physical safeguards at any other location. It may not contemplate all the places that EPHI is held or transmitted, for example, mobile devices. And so, I can tell you, in any security rule investigation, our we're always going to ask for the risk analysis. That's the blueprint. That's the first place we're going to start. And regrettably, that's often where it starts to go off the rails, because as we dig into that, we can see this really isn't in accounting for all the risks and vulnerabilities of confronting protected health information. And then that means your audit controls, if you haven't accounted for all your information systems, then you may not have audit controls on all of them. So now you haven't complied with that section, or your access controls. We've seen instances. One of our more recent enforcement action dealt with protected health information left unsecured on the internet. So again, you might look to the risk analysis as to how did that occur. So it's a big problem. I'll touch on it now, and so I perhaps can do it much quicker at the end. But we do have some resources to help with risk analysis. We did a video 2 years ago, and I have a slide on that, just talking about the risk analysis requirement, some of the common deficiencies we see in investigations, and the things that regulated entities need to do in order to develop a compliant risk analysis.
Thank you. Now, we do have another question, but I know that you have more to go through with us in the presentation. So if you could just keep this question in mind in terms of if you could discuss the OCR audit process and your expectation for the program going forward. If you could weave that into I know that you've got great slides coming up next.
Sure, I'll answer it now, so somebody doesn't lose that that thread. So we haven't done HIPAA audits in a few years. We are planning to do HIPAA audits in the very, very near future. We're actively developing our plan for it, and once we're in a position to launch the audits, look to our website. We'll share that information. But we've used HIPAA audits as something separate from our enforcement program, and so we do a lot of investigations based upon receiving breach reports, receiving complaints. Sometimes we'll initiate compliance reviews based upon information we see in the media. For instance, if there's a media story about a bunch of health information found in a dumpster and nobody reported a breach to us, we might initiate a compliance review. Audit has always been used as, let's take a look at a sliver of the industry that perhaps isn't coming to our attention through the reporting of a breach or the reporting of a complaint or a mechanism that generates a compliance review. And it's always been an open question, perhaps. Like the instances where we see the challenges in implementing the risk analysis, is that representative of the entire industry, or is it representative of a sliver of the industry that is reporting a breach or had a complaint filed against it? In other words, is there a greater likelihood of there being compliance issues with entities that are the subject of a complaint or a breach report or a media report about a potential HIPAA violation? And so the last 2 audits that we performed, we looked at risk analysis among other provisions. And unfortunately, and you can look, we did an industry report back in 2020 highlighting our findings from the last audit. But what we found is it's largely mirrors what we see in enforcement. So the same problems that we see in our investigations and breaches and compliance reviews and complaints, we also saw in the audits. And so, this upcoming audit, we're still working out the details of what provisions of the HIPAA rules we want to focus on, the size of the audit, et cetera. But we will update our audit webpage and provide information. So stay tuned to that. And again, the risk of repeating myself, it's another great plug for our listserv announcement. All of OCR's activities, information, such will be published via our listserv. So please stay tuned to that.
Thank you.
Okay, next slide. This section is just some data that I think is helpful if you caught my act in October. This will sound familiar because we're still in the middle of these same trends. Some of the numbers have changed. I'll touch on that briefly, and then we'll move on to some enforcement actions. This first slide here just shows the large breaches received and the number of individuals affected. And you can see just a substantial increase in the large breach reports received. It's a 102% increase from 2018 to 2023. And then more stark, more damning, really, it's the increase in the number of individuals affected. It's 1,002%. You heard that correctly. 1,002% increase from 2018 to 2023, 15.2 million to 167.9 million. And the 2023 number still, it keeps going up. And you may be thinking to yourself, why is it going up? It's 2024. A lot of the breach reports we received in 2023 that are currently under investigation, and the numbers sometimes change during the course of our investigation, and we update that as quickly as we can. And so that number has continued to go up throughout the year. That's not unusual. There usually is a little bit of a lag for the preceding year, just as that information comes to light, or as the regular entity gets more information and discovers the scope and extent of the breach. Just from 2022 to 2023, we see a 200% increase in individuals affected, 55.9 million to 167.9. And some of the large breaches that have been reported in 2024, we anticipate 2024 is going to be even larger than 2023. So we're in the midst of a very disturbing trend in terms of the number of large breaches occurring and the number of individuals being affected. So what's causing all this increase in large breaches reported to OCR? Next slide, please. Here's a couple of pie charts. The one on the left shows you a cumulative history of OCR type of large breach reported to OCR over the years from 2009 through 2023. And then the pie chart on the right is just for this year through last month, November. And so you can see cumulative historical data, 2009 to 2023, hacking's the largest percentage, 51%. Unauthorized access or disclosures, 23%. Theft is 18%, so those are significant. But the chart for this year shows, far and away, hacking's the most common type of large breach reported at 81%. You can see the trend movement as theft has decreased significantly as a type from 18% to 2%. And this is largely consistent with what we've seen in the last couple of years. Hacking's been about 79% of the large breaches reported at OCR annually. And so we're sticking with that trend. Next slide, please. Here's maybe a little different way of seeing this information involving the increase in hacking. This time it's separated out by hacking and ransomware. And so you can see there's been an 89% increase in large breaches involving hacking from 2019 to 2023. And then from ransomware, it's 102% increase for that same time frame. So if you didn't know it already, this is the largest cybersecurity threat facing the healthcare industry. It's all ransomware and hacking. Next slide, please. This is about the location of the breach. So the previous slides were about the type of breach. This is about the location, same parameters, historical data on the left, current year on the right. Historically, we see network servers, 36%, email, 22%. Those are the largest locations, papers at 14%. 2024, you can see network servers are even more dominant, 62%, email staying constant at 22%, paper records is reduced to 6%. And so, I mean, to sum it all up, it's network servers and emails account for 84% of the large breaches reported to OCR annually, at least this year. And, there's, as you might imagine or expected, there's been a significant movement away from paper records as the location of the breach. Next slide, please. Here's just a way of isolating the network servers, and you can see the increase. It's a 325% increase since 2019. It's not just hacking, although that's you saw it's the largest category. It can also just be health information left unsecured. It wasn't set up right. Somebody made a mistake, doing an upgrade or something. But it's health information left unsecured on a server would also fall in this category. Next slide, please. And then this is email. Email, it's certainly phishing attacks is a large chunk of it, but it can also be instance, workforce member sends health information to the wrong email address or group email. 35% decrease since 2019. So perhaps a little too early to say we've peaked in the end of email as a trend, but something to stay focused on. But it's still the second largest category. So again, network servers and email are your two primary locations. Next slide, please. And next slide. Here's a list of the recent HIPAA actions we've announced, enforcement actions in the last year or so. As you can see, December, not even halfway through the month of December, we've announced a bunch. I'm just going to run through these quickly by category. All of these press releases are available on our website, so you certainly access them and study them. If If it's a settlement, the resolution agreement is published so you can see what the covered conduct was and what were the remedies that OCR sought. If it's a civil money penalty, you'll see the amount of the penalty as well as the notice of proposed determination that was submitted with to the court. The issues on this list involved ransomware. That's the Green Ridge Behavioral Health, Heritage Valley Health System, Cascade Eye and Skin Centers, Providence Medical Institute, Plastic Surgery Associates of South Dakota, and Bryan County Ambulance. So we do try to follow the trends. It's a huge category of ransomware because that's what's happening. Some phishing attacks, that's LaForge Medical Group and Children's Hospital, Colorado. Malicious insider identity theft ring, Montefiore Medical Center. Right of access continues to be a big one. Optum Medical Care, Phoenix Healthcare, Essex Residential Care, American Medical Response, Gums Dental Care, Rio Hondo Community Mental Health Center. An impermissible disclosure of protected health information, including reproductive health information to a patient's prospective employer. That's Holy Redeemer Family Medicine. Impermissible disclosures of health information to former workforce members. That's work member, I should say, one person. Gulf Coast Pain Consultants. And then our most recent one, protected health information left unsecured on the internet, that was in Mediata Health Group. Next slide, please. I'm going to move a little faster. Some of this is repetitive of what I did in October. You'll have the slides available so you can read it, but just moving into the lightning round, if you will. The right of access initiative continues at pace. We made that an enforcement priority back in 2019. That's still something that we're focused on. We're up to 51 completed actions, 45 settlements, and 6 civil money penalties. Next slide. We launched a risk analysis initiative, part of the conversation we had earlier about how important risk analysis is and the problems. Again, we try to be responsive to the data. If risk analysis is a problem, then we've created a special initiative just to address that and try and complete more enforcement actions focusing on the risk analysis requirement. Next slide, please. And next slide. I'm going to run through these also super fast, but do take time if your schedule allows to take a look at these. There's a high-tech amendment on recognized security practices. So we did a whole video on that about how it applies. You can mitigate the civil money penalty or the remedies that OCR seeks in a security rule investigation. So please check that out on our YouTube channel. Next slide, please. We did a video 2 years ago on common cyber attacks, drawing from our wealth of information from all of our investigations, common attack vectors, common deficiencies. So please check that out. Very helpful. Next slide, please. As I mentioned earlier, we did a webinar. This is a great video walking you through how to do a risk analysis, how it should be assessed, what it means to be accurate and thorough, examples of deficiencies from OCR investigations, resources to help you build a better risk analysis. Please check that out. Our most recent video is on ransomware, again, focusing on ransomware, recent investigations, common deficiencies. It's meant to educate as to how to better protect yourself against ransomware. Next slide. Security risk assessment tool that's been around for years. This can help you build a risk analysis. And so it's downloadable, it's free, but it's garbage in, garbage out. If you don't identify all the places that EPHI is stored in your system, it's not going to magically tell you. It responds to what you do. It takes you through about 156 questions and just helps you more or less create an inventory of all the places that the health information is, so then you can go about implementing measures to protect it. Next slide. We've got a bunch of cybersecurity newsletters. Our most recent one, a really good one, on social engineering, phishing, smishing, baiting, deep fakes, just all the trickery that's going on out there. So please check that out. And at the bottom of the page, you see I've raised this a few times now. That's the link to our OCR listserv page. You go there, it takes you like 10 seconds to sign up for it. And then you'll get an email sent to you anytime we do an enforcement action, a newsletter, a rulemaking, anything that is relevant in the HIPAA space, you can get your information first. So please check that out. Next slide. This is a list of ransomware resources all on one page, that some including HHS, OCR, and outside of HHS, FBI, should you pay a ransom, all that type of stuff. So these are great resources. You'd want to consult these before you experience a ransomware attack, because this will help you in managing through that. And we did it. And I can take
We
questions
do
for a
we
minute,
do have a
right?
question, Tim.
Yeah, please.
Yeah, from Rob again. You highlight network server attacks is increasing and email attacks is staying constant. So how are the networks being accessed? Is that through email, sort of stolen credential of employees?
Sure. So network servers as a location of a breach can be caused by many things. So before we get to hackers and nefarious third parties, it can just be, system misconfigurations. Somebody did an update. Somebody added a new network server. The unforced error is just the entity itself failed to put in authentication requirements, and so anybody with an internet connection can access it. And we've had many investigations on that type of topic over the years. And one of my first investigations, when I first came to OCR back, whenever the heck that was, I called a regulated entity and said, your health information is exposed. And they didn't believe me, right? And I said, I can see it. We have it. And it took a long time to convince them. They were convinced I was legitimate, which is nice. Appreciate that. But they did their own internal assessment and told us, no, it's fine. And like, well, it's not fine. We did an investigation and eventually established that it was not fine. So one category of it absolutely is just unforced error. There is no nefarious third party. It's just, you didn't lock all the doors to your information. Anybody with an internet connection can access it. More specifically, though, in terms of what I think the question's asking, there's a multitude of ways. So, we see weak authentication. The password is password. There isn't multi-factor authentication in place. So that's one category of how people can get, third parties can get access. Former workforce members leave, and they still have access. Their credentials haven't been terminated. That's another one. Brute force attacks are one way. Certainly phishing, emails, the installation of malware that you click on a holiday card, e-Christmas card from somebody that it's actually a threat actor. It's doing a program inside your system. We've had that happen before, and sometimes they nest in there for years, more than 1 year, unaccounted for, and it begins exfiltrating data. So there's a variety of mechanisms. It's not necessarily tied that all network server attacks initiate through email, and so the data is a little bit inconsistent. That email is going down, yet network servers is going up. Network servers, I think, just overall from what we see, is just a broader category, and there's more than one attack vector in addition to emails that facilitates that.
Thank you.
Thank you so much. I know we're about a minute over, but we really appreciate your time. I have a half dozen or so actions, I think, for our work group. So Tantian and I will circle back together and go through other questions that may need to be addressed. And we will get back in touch with all of you via notes. For Tim Noonan, thank you again. We really appreciate your time and effort. And we will have you back as soon as the other rule drops. You can be sure on that one. We wish everyone a wonderful holiday season. And if you are able to join our membership meeting today, I believe it starts at 2 o'clock, the WEDI All Members meeting, please do join that as well. Thank you, everyone. Thank you for your
Great.
time.
Thank you very much, Tim.
Excellent. Thank you, Tim.
Yep. Bye
Thank
now.
you, everyone.
Bye-bye.
Take care. Bye-bye.